Hello, and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to begin our genitourinary series with prostate cancer. And today we're specifically going to look into the localized setting.
Before we jump in, I want to give a quick shout out to all of the fellows and new attendings that passed the hematology and oncology board exams. We know it's not easy, and especially with back-to-back exams, preparing is tough, so congratulations to everyone. Well deserved.
Today's discussion is going to be looking a lot at the initial workup and staging of localized prostate cancer. Historically, much of this would not come across the desk of a medical oncologist. However, as we'll be going over in our upcoming discussions, there has been incorporation of a lot of the systemic therapies into earlier stages of the disease. Even absent of that, it is important to be aware of the different risk factors of early prostate cancer, because this will help you understand more of the disease biology when you encounter this in the metastatic setting.
Yeah, some of this may seem irrelevant to us and more relevant to radiation and surgery. But when you're seeing a patient, especially when they're talking to you about, their decision, it's good to have a background in why we do radiation versus surgery and the side effects for each. So
overall, prostate cancer is a fascinating disease. It's very variable behavior, ranging from very indolent disease that only warrants observation to highly aggressive disease. And it still is a frequent cause of cancer-related morbidity, ranking number 4 in the United States. And it has a significant impact globally.
It remains the most common cancer in men, aside from localized skin cancer, with up to 11% of men being diagnosed with prostate cancer in their lifetime, and many more with prostate cancer that would be found on autopsy that they don't know yet.
The development of the prostate-specific antigen, the PSA, has significantly changed the landscape, as this had gotten incorporated into a screening procedure and led to a higher detection of disease at an earlier state, initially leading to significant treatment, possibly over-treatment. More recently, we've been attempting to refine our approach by optimizing risk categories. In North America, there's evidence that men of Caribbean descent and African Americans have a greater rate of aggressive disease, both locally advanced and distant. However, the specific genes to account for this is unclear as far as my knowledge.
Speaking of genes, there are some genes to look for when someone is diagnosed with prostate cancer and has a significant family history. These include BRCA1 and 2, BRCA2 being more common than BRCA1. This is associated with family history of breast and ovarian cancer. Other genes are HOXB13, as well as mismatch repair and Lynch syndrome. And some of these genes may actually be sporadic and not be associated with family history.
Yeah, it appears that some of these homologous repair mutations such as BRCA2, ATM, CHEK2, and PALB2 are found up in about 12% of metastatic castrate-resistant prostate cancer, BRCA2 being the most common of these. However, the role in routinely testing for these in the earlier stages continue to evolve. Often we will test for these mutations in the metastatic setting, as it can impact our systemic therapy options.
So with the screening PSA, the majority of patients are asymptomatic at the time of diagnosis. Localized symptoms such as hematuria and hematospermia are uncommon. Things like urinary frequency, urgency, hesitancy, nocturia tend to be associated with BPH, benign prostate hypertrophy, rather than prostate cancer.
Usually the symptoms when they do develop is due to a more locally advanced tumor, such as invasion into the seminal vesicle. When these lesions do arise, initial extension will be extraprostatically. It can also cause pressure on the bladder.
Less than 10% of patients will present with metastatic disease at the time of diagnosis. Many times this presents with bone pain. Sometimes you can have extreme cases where patients present with spinal cord compression requiring urgent surgery or radiation. I know I've seen this a few times while working on the oncology floors.
When prostate cancer does metastasize, it typically will involve lymph nodes such as retroperitoneal, iliac, obturator, and hypogastric nodes. Distantly, most commonly will involve the appendicular skeleton, so the pelvis and the spine. And these metastases will be osteoblastic, or also known as sclerotic lesions. Remember, we see osteoblastic or sclerotic lesions most commonly in breast and prostate cancer, with other cancers such as renal cell, myeloma, lung cancer causing typically more lytic lesions. Visceral disease involving the liver and lung are higher risk presentations.
The screening test that is most currently used is known as the PSA, prostate-specific antigen, well named. This does increase as we age, so it's important to look at the reference ranges when you are checking a patient's PSA, because a 50-year-old and an 80-year-old have different levels of normal. It's also important to look at a trend rather than one absolute value. PSA can go up with things like prostatitis, ejaculation, sometimes even long-distance bike rides, and it's important if you have one elevated level to repeat it in a few weeks to make sure that it's not just a temporary increase.
Yeah, this is a normally produced peptide. It's involved with reducing semen viscosity, and some of it does end up being circulated hematologically. Adenocarcinoma actually produces less PSA than healthy prostate tissue, but given the neovascularization and atypical direction of secretion, we do get more PSA released into the blood, leading to a higher measurement of PSA in adenocarcinoma. This makes it a sensitive, although not terribly specific marker. As I've mentioned, once PSA had been noted as a marker for prostate cancer, this had been incorporated into practice as part of a routine screening procedure. However, a screening test is only useful if early detection can lead to differences in outcomes, namely reducing that cancer-related mortality and hopefully improving overall survival. To evaluate this, 2 landmark trials were published at the same year in 2009. One of these studies was American design, one was European. These studies actually had opposite outcomes in the impact on prostate cancer mortality. However, were biased by a lot of conflicting practices in the different countries. So looking at the European study, the ERSPC, 182,000 European men were offered a PSA check every 4 years, compared to a control group who were not offered this. This offer was mailed out to men aged 55 to 69, was powered at 86% to see differences in about 25% in prostate cancer-related death. At 9 years, they found 8% of the patients who were offered a PSA check developed prostate cancer versus 4.8% in the control group. Keeping in mind that patients who would develop symptoms of urinary obstruction or hematospermia or suspicion for prostate cancer would often have a PSA. Prostate cancer mortality was significantly improved in the intervention arm with a hazard ratio of 0.8, probability of 0.04, and this related to approximately 0.7 deaths prevented when 1,000 people were screened. At the 16-year follow-up study, they found ongoing benefit. Notably, they found a decrease in the gap between the diagnosis of prostate cancer and the intervention versus control group. So at 16 years, 13% of the patients who were initially offered a PSA had prostate cancer versus 10% in the control, indicating that many of the men in the control group would later develop a more asymptomatic prostate cancer that would lead to PSA being checked. The hazard ratio of 0.8 was maintained, and the absolute risk reduction was improved to 1.76 per 1,000 men screened. Essentially, this means that we have to screen 570 men to prevent one prostate cancer-related death.
I think an important discussion to have with patients when you talk about the number needed to screen to actually prevent a prostate cancer death, especially when you're talking about the risks of prostate biopsy, which include urinary incontinence, rarely, sexual dysfunction, infection.
Now, the North American trial, which was the PLCO, had different outcomes. So in this study, 76,000 men were studied at multiple United States centers, and they were offered either once a year PSA checking for 6 years versus usual standard of care. This was also men of the same age group as in the European study. And once again, the primary outcome was prostate cancer mortality. Of note, in this study, 40% of the patients in both groups had a prior PSA within the past 3 years. And this reflected American practice where PSA checking was available versus in Europe where this had not been the standard of care and not necessarily an available test to all men. At 10 years, they had follow-up of 67% of the men. The study was run with annual surveys being sent back out to the men initially tested. They found in the population there was 92 versus 82 patients who died from prostate cancer, hazard ratio of 0.91. At 15 years, they had 255 deaths in the intervention arm versus 244 prostate cancer-related deaths in the control arm. But however, it's worth noting in the control arm, 86% of the patients had a PSA checked at one point. So although this test was negative for positive outcomes, it was a highly conflicted study. There was a subsequent meta-analysis looking at 5 studies at PSA screening. However, the largest of them were the 2 that we've mentioned, and those drove most of the information. There's also a Canadian, UK, and Swedish trial in part of the meta-analysis. There was a lot of variability between the trials and limitations in the total number of patients who were following up. This meta-analysis also found no significant improvement in all-cause mortality or prostate cancer-related mortality.
So due to these studies, the USPSTF changed their guidelines in 2018, right when we were in the middle of residency, to state that doctors should have shared decision-making conversations with patients regarding the utility of PSA testing. So you should bring it up and discuss with them, but you don't necessarily have to recommend it.
Yeah, these recommendations in the United States are pretty similar to the recommendations that we see in other guideline bodies. In Canada, the guidelines recommend against routine screening, but suggest worth considering a discussion if a patient's in the age range of 55 to 69. The UK also has similar guidelines in place. Basically, all of these guidelines boil down to ask your doctor and have a discussion of whether or not PSA checking is right for you. I think the European study is the purest of these, and we do see that there is maybe a slight improvement in prostate cancer mortality in people who get screened. But as Ryan has mentioned, this is at cost of extra testing, potential biopsies, and the reality that most patients in the control group may identify their disease at some point with symptoms down the road and certainly have a lot of other competing risks towards their overall survival.
Of note, the USPSTF does recommend that if you're over the age of 70 that they recommend against screening. So these guidelines really only apply to men 55 to 69. It also doesn't account for patients with a family history of prostate cancer, and in many of these studies, African American and Caribbean men were underrepresented.
Looking back at our 4 hallmarks of a screening test, number 1 being that this needs to be an important health issue. Well, metastatic prostate cancer is certainly an important health issue. Number 2, whether or not there's an available treatment should cancer be diagnosed, and we'll get to the fact that there are many possible treatments available for prostate cancer if it's diagnosed. Number 3 is whether or not the test is cheap, sensitive, and specific. Well, PSA is relatively cheap. It is sensitive, and not necessarily the most specific. So kind of uncertain there. And number 4, does early detection lead to better outcomes in our patients? And I think this is the big question. And unfortunately, given all the limitations with these studies that were done before, these are still going to be issues with testing in the future. And I think it's unlikely we'll have a clear answer on exactly how to best, but hopefully maybe we can get better information on who is to most benefit from screening.
So if a prostate cancer is suspected, the diagnosis is confirmed by prostate biopsy, which is done by urology and usually via transrectal route, usually with either ultrasound or MRI guidance. I think with prostate cancer, it's very useful to look at diagrams with the actual anatomy of the prostate gland to see exactly, what is being biopsied and the relationship to other organs, such as the seminal vesicles. I know for me, when you read the biopsy report and it talks about the different cores, I had a hard time visualizing it until I was able to look at a diagram and really understand the anatomy.
Yeah, this is a unique type of biopsy. Unlike other biopsies where we take an individual core, at least 10 cores are obtained during a prostate biopsy, with additional cores removed at an area that might be of concern, either on physical exam or with an MRI.
One thing to note is that the prostate biopsy does not biopsy the anterior zone. So if you have somebody that you're suspicious for prostate cancer and they get a biopsy which is negative, it might be useful to get an MRI and take a closer look at the anterior zone because you might need a different type of biopsy to reach that area. The majority of prostate cancers arise from the peripheral zone, which is the area that's palpable on the DRE, digital rectal exam, and are easily accessible by a biopsy.
Pathologic interpretation of the biopsy cores will provide information including the percent of each core that's involved with adenocarcinoma, the total number of cores involved, and also importantly, the adenocarcinoma in each core will be assigned a grade called the Gleason grade.
The Gleason grades range from 1 to 5, 1 being the most well-differentiated, has glands, and appears very similar to normal prostate tissue. And Gleason 5 is the most undifferentiated with no glands. They determine the final score by adding the 2 most prominent histologies, because as we said, they do multiple cores of the prostate. So for example, if you have one area that's a Gleason 3 and one area that's a Gleason 4, the total would be 7. Of note, if there's an area that's the 3rd most prevalent, that's a Gleason grade 5, this would want to be included in the score. So this would be used in place of the 2nd most prominent histology. So if you have a 3 and a 4, but then the 3rd most prevalent is a Gleason 5, it would be considered a 3 and a 5.
In practice, I've never seen a Gleason score assigned less than 3, and the nomenclature for this is going to be usually written as the sum of the the scores that Ryan mentioned, so the predominant and next most common, such as 3 plus 4 in brackets, followed by the summation, which would be 7. So in practice, you'll typically see the range of these Gleason scores being from 6 to 10, with 6 being the least aggressive and 10 being the most aggressive of a prostate cancer appearance.
You'll also see, which has been in practice since 2014, the Gleason grade groupings, which actually make things a little bit more simple. These are derived from the total Gleason score. The lowest Gleason group 1 would be a total score of 6 with a 3 plus 3. 2 is a 7 with 3 plus 4. Group 3 is also a 7, but 4 plus 3. Gleason group 4 would be a score of 8, and Gleason group 5 being 9 or 10. And these groupings have been validated to reflect the prognosis.
Although very helpful predicting the risk of disease progression and need for intervention, the reporting of Gleason scores are notorious for having both inter-reader and inter-institutional variability, which is unfortunately a limitation to the value of these tests.
Another note about pathology, so the most common by far type of prostate cancer is adenocarcinoma. This will be positive for androgen receptor, so AR, also positive for PSA, positive for NKX, and negative for CK7 and CK20. Rarely there can be other cancers in the prostate gland, such as ductal mucinous, and rarely we can even see small cell prostate cancer. This behaves very aggressively, like small cell lung cancer, and the classic presentation of this is when you have a very aggressive disease with a normal PSA and no response to androgen deprivation therapy. And this is treated similarly to small cell lung cancer with a platinum doublet. Patients can also start out with adenocarcinoma and actually transform to small cell cancer of the prostate during treatment.
Staging for prostate cancer is a little unique as well. Unlike many of our other cancers, it does not primarily depend on TNM, although this is part of it, but will also incorporate the Gleason grade group as well as the baseline PSA to risk stratify and inform prognosis. The T staging depends on whether the lesion is clinically palpable. So if it's not clinically palpable, it's T1. If it's confined within the capsule, which would be a T2. Whether or not there's evidence of extraprostatic extension with seminal vessel invasion, which would be a T3, which would either have to be determined pathologically or using a prostate MRI. And whether or not there's other organ invasion other than the seminal vesicles, such as the bladder or the rectum, which would be a T4. Nodal staging is either going to be N0 or N1, and N1 are what are considered to be regional lymph nodes. It's a little unclear sometimes what falls under the regional lymph nodes, and often I find myself needing to confirm with radiology. But in general, it's thought that any lymph nodes that are below the bifurcation of the common iliac, and once again, this may not be immediately described on a radiology report, so it's important to clarify. Because anything above that falls into distant disease and will be considered to be M1. It's M as in Mary 1. And managed differently. M staging is either going to be M1A, which is distant lymph nodes, M1B, which is involvement of the bones, or M1C, which is visceral disease.
In terms of imaging required for staging, really the only imaging that you need is a prostate MRI, which can give you a detailed look at the anatomy. And with whole body imaging to look for metastasis, really reserved for the high and very high risk groups. Usually
these MRIs will be ordered by your urologist, but if you find yourself in a position where you are ordering it, remember this is called a prostate MRI, not a pelvic MRI. Like imaging of the pancreas, it's important that the highest resolution is very specific to the organ of interest, and that's going to better identify nodules as well as regional lymph nodes. So really more important than the TNM stage is the risk stratification groups. There's a really good table in the NCCN guidelines and other tables, if you Google this, that'll probably be easier to follow rather than us going through it verbally. But we'll go over some of the high points. There's many different risk stratification criteria out there. Probably the two most immediately known to me are the ESMO risk criteria, which is separated into a low, intermediate, and high risk, and the NCCN, which uses similar findings but has further subclassified into very low, low, intermediate, which has been broken up into unfavorable or favorable, high, and very high. So a bit more complicated, and all of this is to try to determine how likely this prostate cancer is to progress. These criteria are based upon some fundamental understanding that we've known for a long time, namely that the risk of distant spread at the time of initial diagnosis is very low if the primary tumor is either T1 or T2, if the PSA is less than 10, and if the Gleason score is less than or equal to 7, and that the risk for distant spread is much higher when the PSA is greater than 20, or if the primary tumor is a T3 or T4.
Yeah, so because of that, in order to calculate the risk groups, the most important things to know are the PSA value, the clinical T stage, and the Gleason grade.
I think it's a little difficult to go into all of the NCCN sub-details, and once again, there are very well-defined tables out there. The ESMO criteria is a little bit more straightforward. In order to be a low risk, you must meet all 3 criteria, which is a PSA less than 10, a Gleason score of 6, and the primary tumor being a T1 or T2A. A high risk where you meet any of the criteria of a PSA greater than 20, a Gleason score of 8 to 10, or the primary tumor being a greater than or equal to a T2C, and intermediate risk being anything less than that without an individual high-risk criteria being met.
The NCCN criteria also take into account the number of cores positive on the prostate biopsy, as well as the percent of each core that's positive. And again, they have a very low risk group and very high, and they also separate the intermediate into favorable and unfavorable.
If using the ESMO criteria, given the increased risk of distant spread, we would consider imaging for distant disease for intermediate or high risk. In the case of NCCN, this would be considered if the disease is intermediate unfavorable, high, or very high risk.
Options for imaging include CT, abdomen, and pelvis, so no need for chest CT, as well as PET CT. One of the newer imaging modalities that has become popular over the past few years is what we call PSMA PET, and this is a PET CT that uses a radio tracer that attaches to PSA and can be more sensitive than regular PET CT.
The PSMA PET is certainly shown to pick up a lot more lesions, is much more sensitive, and is a highly specific test, and is being incorporated into the practice of care where it's available. If PET imaging is not available to you, it is important to have some form of test to evaluate the abdomen, looking for lymph nodes, and the bones. So if you do not have a PET, the CT, abdomen, pelvis, and some sort of bony imaging such as bone scintigraphy or full body MRI.
So once we've determined which risk category the patient is in, the next step would be determining which treatment option is appropriate. The main options that we have are surgery, which is a radical prostatectomy plus or minus lymph node dissection, as well as radiation plus or minus androgen deprivation therapy afterwards. And the final option would be brachytherapy, where radiation is administered using beads directly placed into the prostate, plus or minus androgen deprivation therapy. The other option would be active surveillance. So as we said, many of these cancers are very slow growing, and if we didn't do screening, they probably would have never caused a problem for the patient. So patients with low-risk disease do have the option for active surveillance. Now, active surveillance is different than watch and wait, which is actually a common test question. Watch and wait means that you don't do any testing. The patient just comes to you if they have any symptoms. Whereas active surveillance means that you're actively monitoring the patient with PSA checks or digital rectal exam, or sometimes even prostate biopsies periodically.
As medical oncologists, we are not the best equipped to discuss all the potential side effects with these different radical interventions. However, given the location and the extent of procedures that are done around the prostate, things such as erectile dysfunction, sexual dysfunction, pain, urinary incontinence, and potential for bowel concerns all must be considered and would be discussed with the proceduralist. Surgeries can be either robotic or open. Radiation can be external beam radiation, SBRT, brachytherapy, as Ryan mentioned, and there continue to be more experimental ways of optimizing treatment and minimizing risk. Given this extensive number of options, the question, of course, would be which is the best one to choose. This was looked at with the PROTECT trial, where patients were randomized to either a surgical, radiation, or active surveillance approach. This was a landmark study, with its most recent publication being in 2023. And this study specifically looked at men diagnosed with early prostate cancer who did not have a PSA greater than 20 and had primary tumors of either clinical T1 or clinical T2. So the study did not include PSA greater than 20. This did not include T3 or T4, as these patients in general are high risk for progression, and intervention would be the preferred standard of care. Whether or not that's radiation or surgery would be based upon patient and provider preferences. This study randomized men aged 50 to 69, 1:1:1, to either surgery, radiation, or active surveillance. In the active surveillance arm, patients received a PSA once a year and would repeat the prostate biopsy if the PSA were to increase by 50% over the course of a year, with a confirmation PSA done 6 to 8 weeks after that first rise. This is a bit different than what is done in some areas, where urologists are now considering doing PSAs every 6 months, which is the guidelines with NCCN, with consideration of a repeat prostate biopsy regardless of the rise of PSA. This approach may vary depending on which country or location you work at. The primary outcome for the study was prostate cancer-related mortality at 10 years, with the secondary outcome being overall survival. This was a large study. They randomized approximately 550 patients into each arm, and looking at the patients who were involved, about 77% of them would meet the current criteria for low risk. This is mostly a low risk patient population. However, given the size of the study, there were a notable number of patients who met intermediate risk, which would have been about 24% of the patients, and 9.6% of the patients would meet high risk criteria using our modern nomograms. The study was run in the UK, and they had excellent follow-up, with outcomes in 98% of patients known at the 19-year follow-up. However, it's worth mentioning that about 100 patients in each arm did end up having treatment other than what they were allocated to. Looking at the intention to treat outcomes, though, there was no difference in prostate-related mortality. At 15 years, the risk of prostate cancer-related death was 3.1% in the surgery arm, 2.2% in the radiation arm, and 2.9% in the active surveillance arm. Median overall survival was similar between all three arms. The active surveillance group did have a higher risk of metastatic disease, which was 9.4% compared to about 5% in each of the other arms. However, this was most commonly in the lymph nodes and was ultimately treated with androgen deprivation therapy. Importantly, 24% of the patients in the active surveillance arm never required any further intervention, and about 10% of those patients had intermediate risk disease. So although the intermediate risk group was relatively small, there is still a sizable number of these patients who did not require any form of intervention. And I think the take-home findings from the study is, especially in patients with low risk, but also worth discussing with patients with intermediate risk disease, is that all three of these options are just as likely to lead to the same overall survival and prostate cancer-related survival. And I think the risks and balances of the toxicities that come from either surgery or radiation have to be balanced against the risk of stress and ongoing follow-up with active surveillance, especially as still a large number of these patients will require some treatment at some point down the road. And I think the patient's age, comorbidities, and personal preferences will impact on which pathway to choose.
So the treatment of localized disease many times also involves androgen deprivation therapy, but we will be getting into this in the next episode.
Yeah, we realized this was not much medical oncology for a medical oncology podcast, but we do think that these are all important concepts to be aware of and help orient ourselves as we move into more aggressive variants of the disease.
So with that, we'll get into our bottom lines. Prostate cancer is a very common cancer, the most common cancer in men, secondary to localized skin cancer, with approximately 11% of men being diagnosed in their lifetime.
Although this cancer has variable biology, it still is a significant cause of morbidity and mortality, and it's important to identify the disease that's going to be more likely to benefit from an earlier intervention.
There are several genetic mutations that are associated with the development of prostate cancer, including most frequently BRCA2, and these commonly present with metastatic disease. So all patients who present with de novo metastatic disease should undergo genetic testing.
Screening for prostate cancer using the PSA and digital rectal exam is controversial. It may identify disease earlier, however, has not shown a significant impact on overall survival, with potentially a small impact on prostate cancer-related mortality. And most guidelines recommend shared decision-making discussion with their primary care provider.
That being said, many of the patients diagnosed with prostate cancer are diagnosed in the localized setting and are asymptomatic with just an elevated PSA, with a small minority of patients presenting with bone pain or cord compression from distant metastasis.
If prostate cancer is identified, transrectal biopsy is performed, and using the resultant Gleason grade clinical stage using a prostate MRI, and the absolute value of the PSA helps determine a patient's prognostic stage, which will typically break into a low, intermediate, or high risk classification.
The treatment options for the different risk groups can vary from watch and wait, active surveillance, radical prostatectomy with or without lymph node dissection, radiation with or without androgen deprivation therapy. And this depends on patient preferences as well as the risk grouping.
We have strong evidence to support that in patients with low risk or very low risk disease, that there is no difference on overall survival or ultimately in patient outcome whether or not they proceed initially with surgery, radiation, or an active surveillance approach. It's worth noting that although 25% of patients with active surveillance did not ultimately require any treatment, that still leaves a substantial number of patients who ultimately at some point would have their disease progress requiring radiation or surgery. These low-risk patients warrants a surgical consultation, a radiation consultation, and an in-depth discussion on the risks and benefits of intervention or observational approaches. In patients with high-risk disease, this is a PSA greater than 20, a T3 or T4, or Gleason 8 to 10 score. These patients are high risk for developing distant disease, and if a candidate for a radical approach, should discuss surgery or radiation. In patients who are older or frailer, an observational approach may be considered. For patients with intermediate risk disease, this is also a challenging discussion to have. Even though this was a smaller percentage of patients in the PROTECT trial, there did not seem to be an impact on mortality for the intermediate risk disease patients who proceeded with active surveillance, and still a sizable number of patients who did not require any further surgery or radiation and remained without progression, even at 19 years follow-up.
Well, I think that wraps up our first discussion on localized prostate cancer. Next up, we'll be talking about the addition of androgen deprivation therapy and other novel agents.
Yeah, this has been a fascinating disease, especially over the last 10 years. A lot of new drugs have come to the management of prostate cancer, and many of them, almost all of them, not being chemotherapy.
So thanks for listening and happy holidays, and hopefully we will record again before the new year.
If we don't see you beforehand, I hope everyone's 2023 ends well, and we look forward to seeing you as we move forward here. Thanks as always for listening.
Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.